Some of the symptoms of SI dysfunction include pain at the SI joint, which is sometimes by patients perceived as low back pain. At other times it's perceived as posterior hip pain. Patients sometimes will experience difficulty with ambulation. They oftentimes note hurting when lying down, and then when they initially stand up, an increase in pain is followed by initial relief of pain that worsens with ambulation. So SI dysfunction can arise from quite a few conditions. So one can have degeneration of the SI joint, inflammation of the SI joint, or even instability of the SI joint. We've seen SI pain after lumbar fusions, and particularly L4 to S1 fusions. We've seen a fair amount, I should say, of SI pain. It's important to have the proper diagnostic workup. And there are different thresholds out there, but I think the one that probably the most conservative threshold is to make sure that a patient has 2 sacroiliac joint injections, well done sacroiliac joint injections, that give the patient greater than 75% relief of the symptoms that they're complaining of. If a patient achieves that, in my experience, if you follow those successful greater than 75% relief of pain, SI injection with an MIS fusion, those patients tend to do quite well. The procedural length is actually not the issue with these. These, for most spine surgeons, are actually quite straightforward procedures. It would take 30 minutes on average, I would say. So I know surgeons that do it in 15 minutes, and I know surgeons that do it in 45, but generally about 30 minutes is the length of time for the procedure. So the SI joint in its native existence doesn't move a lot. Okay, we're talking about really just a few degrees of motion, and not motion in the typical flexion extension sense that one may think, or even rotation. It's kind of a combination of that, and even that motion is only a few degrees, maybe 3 to 5 degrees of motion. The goal is to eliminate the motion. So essentially we want to stabilize the SI joint. Some of the thought process is that if there's frank instability whereby the ilium is actually shifting from the sacrum, which is unusual that you would see that grossly, where it's just, gross shifting. But if there's micro motion that's causing the SI dysfunction, then by placing the screws and performing the fusion, that will eliminate that. If there's inflammation, usually stabilization of the inflammation will allow it to calm down. And hopefully, most of the inflammation can be treated conservatively without SI fusions, but if necessary, the SI fusion after appropriate workup is an option. If there's instability, or if there's too much motion in the SI joint or too much stress on the SI joint, then it needs support. If there's too much stress, if there's too much motion, you need to eliminate the motion. I like the screw because I can place it across the SI joint and then I can gain some compression across the SI joint. I personally don't think that it makes a lot of sense, in my mind, to place a device across the SI joint that doesn't compress it, because then the joint can just toggle on both sides of the device. So you can gain additional stability by compressing the joint, plus you have the support of the device across the joint. That way when the patient stands, hopefully the compression can occur, as opposed to if the device is not compressing and the joint is open just a little bit. When you stand in it, your inner sacrum can settle down, so there can still potentially be motion. These are small devices. These are not huge devices. So we have to think that there needs to be more support from the actual patient's anatomy as opposed to just the device alone. Sacroiliac fusions have been around for decades, right? They've been tried, and earlier data did not really suggest that they work that well. And so now we have newer technology that we're employing to try to gain success with this particular procedure. You know, some of the things that the device needs to do, because it's small, is allow for bony on-growth. Because we can get bone within the device, but what we really need is for the on-growth on the device on the ilium side as well as the sacrum side, so that is in there firm. Also, it's nice if a device is fenestrated and allows for bone as we're placing it in to be pulled within the device, then that on-growth in combination with the fenestrations that has allowed bone chips to get inside, and then also if the surgeon can pack some chips inside, then that's just generating more stability. So when you have a small device, you need as much biology on your side as possible, and hopefully, in my opinion, the design of the device should encourage biology.